Welcome everyone to the second session, and good afternoon. I'm excited to be moderating this session. Thanks again for continuing to stay and for your participation. I'm Dr. Nnaji, a transplant nephrologist at Downstate Medical Center. I will start by providing a brief background or introduction. We talk in ACLS about chain of survival. In transplant, I think we also do have what I call chain of success or chain of barrier, depending on how you want to look at it. This chain starts with referral of patient with advanced CKD, that's CKD 4 or 5, to the transplant centers. It continues with evaluation and listing of the patients, wait list management to optimize the number of patients on the active list, increase acceptance of organs or reduction in discard rates, which Dr. Roshan emphasized and talked so much and passionately about in her lecture. Optimal management of patient post-transplant to improve long-term outcome. The reason why I like this concept is that it draws our attention to the fact that we have multiple barriers at different levels, which patients must navigate before they are transplanted. A multifaceted strategy must be used to increase transplant access for our patients. And that is what we have been doing at our center for the past 2 years since Dr. Roshan took over the leadership. We have focused on increased referrals to transplant centers, increased number of referred patients who are evaluated and listed in a timely manner, increase in number of listed patients on the active list through efficient wait list management, increase in the percentage of organ acceptance to decrease discard rate. Increase in supply of organs is also one of the important strategies. Optimizing disease organ pre-transplant management, optimizing recipient health. One of the questions we got during the first session was on a patient that died within the first 3 months from a cardiac event after transplant. Underline the importance of optimizing recipient health and management. There's also an issue of eliminating financial, geographic, economic, social, and racial barriers and inequities. Dr. Markel talked extensively on this. I would like to say that I prefer the term social influencers of health rather than social determinants of health. My reason for preferring this term is that the term social determinant of health brings with it the connotation that these are factors that we have, or we have very little that we can do about them. But social influencers of health suggest to us that these are factors that we can and should be addressed to optimize health or transplant. I believe that in future, we may achieve access for all through donor tolerance induction, achieving excellent transplant across ABO barriers, growth of adult stem cells, and hopefully xenotransplantation. The focus on this session is on improving long-term outcome. Most transplant centers have excellent one-year graft and patient survival. Long-term graft survival, however, has been suboptimal. The graft attrition rate is high and has not changed much over the years. Data from the SRTS in 2021 shows that 20% of patients on waiting lists have had previous transplants. This is an important barrier to transplanting patients because we know that the more number of patients we have on the waiting list, the less likelihood that an individual patient will get a transplant. Various factors are responsible for this poor long-term graft survival. The presenters of this session will be talking to us about some of these factors through case presentation. We have a great set of speakers lined for this session, which has been divided into 2 segments. The first segment has 2 speakers, and each will be speaking for 20 to 30 minutes. There will be 10 minutes of question and answer session at the end of the first segment. The speakers will remain in the podium until the question and answer section.